I'm attending the acute leukemia meetings in Munich. This is a traditional meeting that's gone every 2 years for the last 20 or so years, and usually attracts most of the investigators in acute leukemia studies. So I was asked to present data in relation to the core binding factor leukemias, particularly in relation to whether GO, Gemtuzumab ozogamicin, would be beneficial. So we've run trials involving these patients for the last 25 years, and a number of interventions have taken place. So I reviewed data on nearly 1,100 core binding factor leukemias and looked at the different interventions that we had made over the years. These included whether we used our traditional consolidation therapy, including amoxicillin and etoposide, or whether we give RSC, which is the usual standard of care, and what the dose of the RSC should be. We also questioned induction with different chemotherapies, including giving them FLAG-IDA. And the main study was that we incorporated the immunoconjugate Gemtuzumab ozogamicin, or Mylotarg, with the first course of treatment in a trial called AML 15. And in the core binding factor leukemia, we found that this made a very significant improvement in survival. In the following studies, these different interventions took place, and we were able to look at whether it was just the GO that improved the outcome. The outcome had gone from 50% survival to 83% survival with 8-year follow-up. Was this just due to GO or were there other matters? And we found that GO plus RSC in consolidation plus standard chemotherapy augmented each other. So the GO result was improved if you used RSC. If you didn't use GO, RSC wasn't quite as good. FLAG-IDA turned out to be rather good, but the numbers were very small. So the message at the moment is that the GO survival has improved fairly dramatically, and if I had it, I would ask my doctor to give me GO with my course 1. I would like that to be 3 milligrams on a single dose, and I would like him to give me RSC probably at 3 grams as my consolidation. I don't need more than a total of 4 courses of chemotherapy. We've shown that previously. If I looked at the MRD status of after the first or second course of treatment, I would see that if they received GO, their survival was very good, even if they were MRD positive. So the next questions, I think, are: does FLAG-IDA, a better, more effective induction therapy, increase matters further? Could it replace GO? Is it just as good as GO? We don't know, but that's going on in trials that are ongoing in the UK at the moment.